So greeting to all the students. So today we will be discussing on the topic Mucocele. So what is a mucocele? It is a most common salivary gland pathology. So mucocele is considered to be a lesion of traumatic origin. So most commonly involves ducts of minor salivary glands. So what is the etiology? So the cause of the mucocele is usually traumatic severance or cut off of the duct, or it can be due to chronic partial obstruction of the minor salivary gland canal. So clinical features, there is no specific age or gender predilection. So the most common site for formation of a mucocele is the lower lip, followed by buccal mucosa, the palate, cheek and floor of the mouth. So, as we already told, it is the most common salivary gland pathology. And it is considered to be of the traumatic origin and involves ducts of minor salivary glands. So, etiology is due to traumatic severance of the duct. So, that is normally due to habitual chewing or biting of the lower lips or accidental biting during chewing. So, due to the trauma, the minor salivary gland duct can be cut off, causing saliva to pool. So, the mucin will pool into the epithelium. It also occurs due to the chronic partial obstruction, usually caused by salivary canal calculi or calcification within causing the obstruction of the mucin, which causes pooling and expansion of the ductal epithelium. So these are the most common etiology. So clinical features, so no age, and the site, as we already talked, is the lower lip, which is the most common. So how can be the lesion present? So the lesion normally presents as a raised, circumscribed, well circumscribed vesicle, or a raised lesion with fluid collection known as the vesicle with a slight bluish translucency. So the bluish translucency is due to the right reflection from the underlying mucin. So sometimes it may rupture due to habitual biting. So the patient may cut off, or accidental trauma can cause rupture to release the thick mucinous material which was present. So some deep-seated lesions having overlying thick mucosa will appear normal. They will not have any characteristic translucency or bluish color, but since there is overlying thick mucosa, it will appear normal in color with slight swelling. Sometimes it can also recur. So there will be swelling followed by opening and release of the mucinous material. Again, after healing, the lesion will recur. And sometimes the lesion will also enlarge during meal times or during having food, because due to the stimulus, more saliva will be produced, and due to the obstruction, the lesion will enlarge. Now moving on to the types. So clinically, two types are present. So one is known as the mucus extravasation cyst, and the second is known as the mucus retention cyst. So as the name suggests, mucus extravasation cyst occurs due to the severance of the duct and the mucinous material to pooling into the underlying epithelium, causing a swelling. So here there will not be, as studied from the definition of a cyst, so a lesion can be called a cyst only if it has a lumen surrounded by an epithelial lining. So here the lesion does not have a specific epithelial lining. So the fluid is seen just below the connective tissue. So since there is no epithelial lining, we cannot clinically classify it as a. So the mucous extravasation cyst is also known as a pseudo cyst because the lesion mimics a cyst. So also known as classified as pseudo cyst. So then there is the actual true cyst which is lined by epithelium. So here the saliva is formed just due to the hindrance of obliteration of the salivary gland by salivary gland calcification of any other hindrance. So causing dilatation of the duct, and we all know that the duct wall is formed of epithelium, and this kind of cyst which is lined by an epithelium, so classified as a true cyst. So coming to the histology, here the normal tissue is usually seen along with purely defined pools containing faintly eosinophilic mucinous material and also containing mucinophages. So what are mucinophages? Mucinophages are nothing but macrophages which has already ingested the mucin. So they will be phagocytic macrophages filled with mucin. So they can be visualized in light microscopy and they are called mucinophages. So one or more dilated duct may be present or can be seen associated with the lesion which is causing, and sometimes a breach may also be seen. So a dilated duct or a breached duct can be seen in association with the lesion, and since the material is leaked out, there will be inflammatory infiltrate consisting of neutrophils and lymphocytes. So coming to the mucus retention or the true cyst. So here the, as per name also, it is a true cyst since the cyst is partially or completely lined by a epithelium. So the epithelium will consist of flattened cells, sometimes can be stratified squamous or squamous cells or pseudostratified squamous or columnar epithelium depending upon the location. The cystic lumen may contain mucus secretion, mucinophages and inflammatory cell, and along with the lumen and epithelial lining, a thin fibrous capsule will also be present. So what about the treatment? So sometimes mostly the lesion will resolve spontaneously. So a small retention can occur, it can resolve spontaneously, healing of the lesion. But at times it will not heal because due to the constant. So once it is opened, the mucin will leak and then the lesion heals, and again the same thing can happen, causing recurrence of the lesion in the same position. So if the calculus is present, once the lesion heals again, mucus will get collected behind the calculi and the lesion can recur. So in thus cases with recurrence, surgical excision is the treatment of choice. So in this, during the procedure, cyst should be removed along with the associated minor salivary gland and the salivary gland in toto or completely to prevent recurrence. Otherwise, after the lesion heals, again mucin will be produced, it will get pulled, and thus the lesion will occur. So recurrence can be prevented by the surgical excision of the cyst along with the associated minor salivary gland and the duct. So now we will move on to another kind of mucocele known as the ranula. So ranula is a specific type of mucocele which occurs at the floor of the mouth. So why the name ranula? So in Latin, rana means frog. So if you look, so it is seen in the floor of the mouth. If the tongue is raised, the swelling can be visualized, and the swelling will resemble the frog's translucent underbelly. Since the epithelium is very thin, the lesion, the swelling can be visualized just like the soft translucent underbelly of a frog, thus given the name ranula. So clinical features, the lesion will appear blue, dome-shaped and fluctuant swelling on the floor of the mouth. So it will sometimes fill the floor of the mouth and can also elevate the tongue. It is located lateral to the midline. You all know that the glands are on both the sides. You have two glands, one on the other. So usually the lesion will occur in one gland and it is usually seen on the sides, either sides. So it can also rupture and release the mucus contents into the oral cavity. So when the spilled mucin, dissects through the mylohyoid muscle and produces a swelling within the neck. So that those kind of clinical presentation, we call it as a plunging ranula or a cervical ranula. So here the lesion has plunged into the neck region. So histopathology is similar to that of a normal mucocele. We cannot specifically tell whether it is a normal small mucocele or a ranula from histopathology. So in those cases, clinical presentation is very important. And for ranula also, the treatment of choice is again surgical excision of the lesion. So always surgical excision of the lesion is the treatment of choice. So now moving on, this is a brain map of the mucocele. So in this, the different components are the clinical features, etiology, histopathological features, and the management. So the specific learning objective would be to study the different components of the mucocele. So assignment would be to draw a neat concept map for the topic mucocele, which will enable you to study it and remember each component. That is the clinical features, histopathology, and management of mucocele. So the critical pedagogy assignment would be, what would be the outcome in management of mucocele if the involved minor salivary gland is not excised? So you have to find the answer for this analytical question. So what would be the outcome if the minor salivary gland is not removed in toto along with the swelling? So another assignment would be to discuss the causes of recurrence of a mucocele. So that brings to the end of the topic mucocele. Thank you.